You can stay here, and I would like to invite all the speakers of these sessions to come here. I think we have around 10 minutes final discussion, not more, but for questions.
Go. Okay, let's start. For the pictures of the session.
Just a quick question on the diet. With the breakdown of the macronutrients and micronutrients between the diet, like fiber, did you put that up there? I didn't see it, but was there a major difference between them?
Yeah. Since this was only 10 minutes, I reduced the previous presentation where I included this. As for example, for fiber intake, it's around 40 grams, for your diet, 20. And also for whole grain, it's different, and for different it's stated.
Okay, so I have one final question. I'll do this very quickly. When we do these type of metabolomic studies, when we look at cohort and we look at disease end states, I think we need to be very careful. There's two recent publications that looked at polyol. There were polyol associated with cardiovascular disease risk. Polyol can be made within the body and consider replacement, so you can get them from the diet and can be produced endogenously. And these studies only looked at baseline load, and then they followed 3 cohorts for about 40 years and looked at disease states. But it's very difficult to discern between, at least out of my knowledge, between dietary and endogenously produced. And that could be a problem for anyone producing foods that may have those ingredients as well. So I think when we're looking at these different metabolites, it may be also good to look at the source as well, and if they can be produced rather than being exotic.
Thank you very much. More questions? Are you? Okay, we have the first.
Thank you. A question for Marta, to the other people. There are some indexes to evaluate the Mediterranean diet. There is one by Turkey, for instance, but there are also other these indexes, and they have been found to be able to predict. Now I'm wondering if you utilize the metabolism, are you getting a better prediction, or it's almost on the same? Same apply also to other indexes that we utilize, taking into account the cardiovascular disease risk factor, blood pressure, age, cholesterol, HDL. We also utilize these indexes to evaluate ability to prevent cardiovascular disease, and these are used for deciding when to be treated, starting to be said. Is this also being overcome by the marker that you are using with metabolomics and other studies, and the one that was based on clinical features?
Yeah, thank you very much for the question. So I think it's not really whether it predicts more or less when we use the metabolomic method. I don't think it's out for the but it's a matter of to fine-tune a little bit more better mechanism. And I think that the indexes that can be created with running like you do it in I don't want to call it objective because I wanted to say that it's not really objective what we do with this mechanism, but it's really it also can be predicting that it's so this is independent.
Yeah, I mean, think what usually you assume that the measurement error in the metabolite signatures is unrelated to the one in like the dietary assessment, so that is useful and can result sometimes in substantially more precise associations of the metabolite signatures compared with the dietary assessment, like the classical dietary assessment tools. And yeah, I had another point, but I forgot it now. But yeah, anyway. So I think this is sometimes you get much stronger associations. Yeah, and the other thing is that if you derive the metabolic signature in an intervention framework, you also kind of like can circumvent confounding mechanisms.
Yeah.
It's just on that it was not going to no point. That the day you have that impacts your studies and many of the not be free of investing this is or happens slowly influences so that more alive by the increase. So I think that we have to because those many of them having the information that issue is also part and not like all the taxes is also big. I've been we have to consider I remember that the Mediterranean having index actually show very similar. Very
Anything, yes. And concern the so that you have possibility to provide names and subspace. Yes. I hope we need the diet of the time to decide to keep this. It's it. But we look data about friends for all the present there and it was only the consistency but here and it was it's not friends actually. Because in our study of 10,008 it's probably 7 it's a very different rotating the PM with strongly negative associated essentially they have very big functional differences. And thinking maybe that would be one of the reasons this happens in the PM. And all programs are looking at what kind of yeah.
But it was deeper, right? The functionality different.
Yeah. Of course, the development.
One question? Sorry, you can talk if you so very excited to see the influence that see that expanded. So I threw that on a slide as almost a throwaway comment, not we're going to dig in so much. I do appreciate that. The designs you're talking about get to something that is a phrase we often use about responder and non-responder. But in most of our studies, we just see people that had a difference and people who didn't have a difference. And for that, so I was wondering if you could speak a little bit to that in terms of defining the idea of responder and non-responder. No one spoke about some of the precision, deciding it, at which point seeing a difference or not a difference can be included as a response. versus just a failure to observe it different over time.
Thank you. We rarely look at responders, primarily in the child, possibly in a secondary way. One way is when you back about how we present it to that's a very professional about how we talk about statistics. We, in my perspective, maybe we are not from that. And then the responder and that treatment work for you. Well, what if was 0.06 and there was a thing, that person responder or you tell that person should be not responder or continuous measure of ability from here or abilities or help. Maybe that one. Secondary is I can get to define responders and follow up with some additional information. For example, look at the funding system for defining what workforce is. Find how many members are going to do. So then you're using that follow-up file. That's one way how to then that. And therefore you can find the line and taking a more method and taking specific.
Like two is very. Be good to and you can get in without thinking functionally disadvantage. If the trial is visible, you don't necessarily wait then you're looking that anything which see is functionally identical. But you see whether your treatment is both beneficial and the lesson to be adhered to. You can give it an efficacy as well as a likelihood of sustainability. And that can be it's interesting to get doing. Never ever been successful. So maybe you could sort of we can get
something, yeah, that would be nice.
That are the questions we should look at. So we said and where and I'm just picking up some of the points that you mentioned that the very interesting point that we just touched upon. It's actually very interesting. The concept of a challenge for you guys in part of line, for example. We talked about the efficacy of it. So if we're measuring something over time, obviously lining then function. You're taking that eye and that eye. We can random that and arguably random that eye do the other kid. So that's hard to do. So then we might not be but we might just be measuring hearing to the diets and the impact of that, which on a personal level might be anything we care about the work, but you never bring that out. And I think it all comes back to designing those files, maybe in general, but we should do really part of what are we measuring and what's the timeline of the effects of this weight loss actually and the time frame what we want to measure.
Yeah, also for Stefan about itself because I also know the idea. We have plans to do soon, but I'm wondering if the idea because we talked about cultural influence to if any go to a pooling of different trials in the end and then pool estimate and then you get to a group again. But then I think the RCPs, what we used to, we always struggle with homework. Do you have any idea how to deal with that? How you need, or is it the sequence? for the repetitions of the treatment that already power with the injected. So how do you see that?
Talking about the powering trials, there are two elements coming in from the informed trials, which are the number of people and the number of measurements. Then it depends on the dependency of the measurement. One way of looking at this correlation, that's the way of describing this. So what I'm measuring, how dependent are they measuring, how correlated are they measuring over time. If they were independent, then likely, roughly you could multiply those two. Generally, they're not independent, so you lose some power, but you can drastically decrease your time. So it's a way in how long you run your trials, how many people you want. Autocorrelation is an important point, but then also definitely what's the effect. If you want to look at long-term effect, then obviously you get less measurements from. If you're looking at immediate effect, then possibly you can get a measurement every day, every second, possibly. And that might help you to run this trial very, very short. And it's still in.
Last question.
Congratulations to both the speakers. It's an amazing session. I have a question for the last speaker. And perhaps we can time all the panel. The first one is in relation to we don't understand clearly how you have decided the diet, the good diet, the gut diet. So because you talk about oil, for example, which type of oil, and also you have decided some elements that are reaching the Mediterranean diet. So I didn't understand completely.
So my goal for the work on 2,000 papers. The first which microbes created associated with growth. But then if they started created, I think that they proved that 23 pieces of microbes in previous human rights studies. So they did that.
And more than one trial. The consistency was important. So there should be more than 2 trials reporting the same direction of the effect on specific foods on these specific bacteria. Then they were qualified to be included in the measure.
The oil that convention polyphenol. No, because polyphenols is one of the things that change.
The basic diet was a healthy Nordic diet according to Swedish national dietary guidelines, but then replacing those foods where more than 2 interventions had shown an effect, and then adding on top of that fermented food, so replacement of dairy for fermented dairy. So that was this one. There is an algorithm, but it will be presented in the paper.
Because a Mediterranean diet was
So it's a little bit misleading talking about Mediterranean diet. There were many elements that, because there were many interventions showing positive effect on the elements of the Mediterranean diet that were picked up in these gut diets.
So I don't know if I people should pay that fun, but at least in the now we know that we can, for example, identify phenotypes of individuals that respond to different to an intervention in this case of diet. Okay. You see that we will translate this to the health system or clinics, etc. And probably this will be very costly because we have to recommend different things to different persons. This will be very difficult, and you know that the health system, the health system is the cost of the medical doctors and dietitians, etc. This is the most important. So do you think that for these who cause problems, ethical problems, for people, they have perhaps more. So this is, I think that it's difficult to answer, and perhaps we can answer after. But I think this we have to put an answer.
Is there anyone who wants to give one comment? Jordi?
Yeah, so I think it's a very well. I think sometimes something that should be very active with the later things, but it's also true because it can be really in some way, in a way that internet and in a way that things and it's true that also practices is always an issue, but it's an issue that we cannot pandemic. These will have all next year. We have to do something at some point, and prevention is expensive. You have to implement, then you do something. So the way that I see it is making it something that in the future is like more better. They be very risky to say please, because everything is open.
Okay, I think that was an excellent final remark. So thank you all the speakers.